when they're born. So the aims of today's presentation are what strategies we can adopt to improve the nutrition of our preterm babies. And as Dr. Rehan mentioned, that I will try to tailor this presentation to the Pakistani setup and to the resource limited settings. I won't go in much details that what happens in the West, what happens in the UK or America. We'll talk about what we can do in our local NICUs. What is the importance of early feeding in preterm babies, and we'll discuss caloric requirements and caloric contents of different IV preparations, TPN, and different milk preparations. Then we'll talk about the importance of human milk fortification in preterm infants, how to manage feed intolerance, and how to optimize nutrition following discharge from the hospital. And also, I think one of the important discussion today would be that how we should be using standard growth charts when we are following up these babies, not only in the NICU, but also following discharge from the hospital as well. We'll start off with the case, and any participants who want to participate, they can unmute themselves, and I would like that this is as interactive as possible. So please feel free to unmute yourself.
Sorry for interruption, Dr. Yasir. Unmute option is restricted. If anyone raise hand, and we will allow him to unmute. So if anyone want to respond, please raise your hand and you will be unmuted.
I think Yasir and Vikram, if I can say something, if any question, just make it in the end, because too much interruption at that point. Just write it down, whoever the participants are, and in the end we can try to answer as much as. I think that's better if Yasir agreed.
So question answer at the end of the topic.
Just for the case discussion, Dr. Junaid was saying that just for the initial.
Okay. That's fine.
Yeah, just for the initial case presentation, if people could kindly interact. Our case is our 28 weeks preterm baby who was born weighing 1 kilogram. The mother received antenatal steroids and magnesium sulfate. The baby was briefly ventilated, given surfactant, and then put on CPAP, hemodynamically stable. If any of the participants would like to unmute themselves, please raise their hand and tell us that what fluids should we start and what rate should we use in this baby. Anybody? Anyone from the fellows? Fayaz Ahmed, yes. Vikram, can you please unmute Fayaz?
So fluid should be started 10%, and it should be started at 80 to 100 mils per kg.
Okay, and would you consider anything? Which fluids will you start? You said 10% dextrose.
So I would like to keep the combination of the fluid that makes the GIR in the physiologic range, like 4 to 6 mg per kg per minute. So can be 7.5 to 10%.
Okay, well, I think in neonates we probably should always use 10% dextrose as a standard fluid for all newborns. That would give 4 to 6 milligram per kg per minute. Given the fact that this baby is only 1 kilogram, if you're working in an NICU where there's facility for a TPN, would you consider TPN for this baby?
Yes, sir. Starter TPN without electrolytes, with amino acids and minimal lipids, and not lipids on the first day, but amino acid and glucose, definitely.
Yes, very good. So the starting fluid for this baby would be 10% dextrose. The rate could be anywhere from 60 to 80 ml per kg per day, depending upon your local unit policy. And as we will discuss later on, that the 10% dextrose has very little calories. So such a small baby, we cannot leave that baby for long just on dextrose. So if it's possible, if you're working in a unit where there's a possibility of giving TPN, then this baby should be started on TPN as soon as it is practically possible. The next question is when the feed should be started and which milk should be used. So please raise your hands. Okay. Fayaz Ahmed again.
So feed should be started as early as possible and should be express mother milk or donor human milk. And if the status IUGR status is known, then we should start cautious feeding and keep the trophic feed for first 24 hours at least. But it should be started within as early as possible, within first 12 hours of life. If the mother milk is available, if not, then donor human milk. But it should be started as early as possible.
Nadeem Fraz.
Pardon?
There's another participant who wants to speak, Nadeem Fraz.
Hello.
Yes, Nadeem.
Actually, I want to ask about what is a donor milk, because in Pakistan, I think we are not near any mother milk. Can you explain?
Okay. We will talk about donor milk at the end. My question was basically about starting feed. So as Fayaz mentioned, the milk should be started as soon as possible, and it should be express breast milk. Unless there's an absolute contraindication, which we will discuss later on, if the baby is stable, the minimal enteral feed or trophic feed that can be started within as soon as it is possible, preferably within the first 12 hours at a rate of 10 to 15 ml per kg per day. So the next question is how quickly the feed should be increased for this baby who is 1 kilogram baby. Anybody else? Okay, Fayaz.
Sir, usually we start with trophic feeds, 1 ml per kg. Then if the baby is tolerating and there's no abdominal distension and bowel is moving, then we can progress feed every 20 to 30 ml per kg per day. And we want to achieve full feeds by 5th or 7th day of life. But my point is, within first week we should be free of IV fluids and should be on the full feeds. That should be our aim.
Yeah, so that's correct. That the feeds and the trophic feeds are only for the first 1 to 2 days at a rate of 15 to 20 ml per kg per day, and subsequently, depending upon the baby's weight. I mean, this is a 28-weeker who is 1 kilogram, so preferably you can increase by 20 to 25 ml per kg per day. And if the baby is tolerating those feeds, then hopefully by day 6 to day 7, the baby should be on full feeds and off IV fluids, and that should be the aim. And what should be the target feed volume for this baby?
It can be 160 to 180 mils per kg per day.
Yeah. So anywhere between 150 to 160 ml per kg per day would be the target feed volume. Okay. If anyone else wants to participate in the discussion, please raise your hands. And the first question is, what is the optimal weight gain for this baby who is 1 kilogram? Anybody else? Any other fellows? Amandas?
Yeah, it should be 60 grams per 30 grams per day. It should be.
I think for 1 kilogram, probably 30 gram per day is a bit too much. So the optimal weight gain for a 1 kilogram baby is around 15 to 20 gram per kg per day. So it will be around this rate. It's slightly more for the bigger babies, but as we said, our case discussion is about a baby who is 1 kilogram. For a 1 kilogram baby, that would be around 15 to 20 gram per kg per day. That works out about 150 gram per week. that would be considered optimal weight gain for this baby. And what do you think, what should be the discharge criteria for this baby? When this baby can be discharged home?
I think then when the weight is more than 1.8 kilograms and mother is okay with to take care of the child safely, and we should have the outreach nurses to say look after, or we have a very good follow for the arranged follow for the child baby.
Yeah. Mendes, where do you work?
I work in UK.
Oh, you work in the UK, so okay. You're joining from the UK.
Yeah.
Okay, so I think your answer is probably right if you're working in the UK, but from a Pakistani perspective, the discharge criteria is slightly different because of the resource limitations. And you're right, in the UK, the cutoff is 1.8 kilogram. But what happens in Pakistan, because of the different financial reasons, we have to discharge some babies before they reach 1.8 kilogram. The reason being, if a baby who is 1 kilogram, 28 weeks, by the time they reach 1.8 kilogram is about 7 weeks. And most families will not be able to financially sustain that much stay if they're in a private hospital. So
I agree. I worked in Pakistan for 11 years. I agree with this.
So I'll discuss later on that how we can modify the discharge criteria. But you're right, any kind of around 1.5 to 1.8. Preferably that the baby is taking all the oral feeds on the breast. But if possible, we can discharge babies on NG or tube feeding as well, if the parents have been trained with close clinic follow-up. And what milk should be used at discharge?
Same breast milk, express breast milk?
Well, ideally, the baby should be feeding on the mother's breast, if the baby is big enough to feed on the breast. So that should be the ideal, that the baby is breastfeeding. If the baby is unable to take feed on the breast because it's still small, then we can use fortified express breast milk through the tube, should avoid preterm formulas, but obviously there will be situations where the express breast milk or the breast milk is not available. And in those cases, depending upon the weight of the baby, the gestation of the baby, you might either use the term formula or you might need to use a preterm formula for a bit longer time. Again, that is the decision that has to be taken based on the individual patient's previous history and background. And how the growth should be monitored following discharge. How we should monitor the growth. Anybody else? Please raise your hand if you want to answer this question. How the growth should be monitored following discharge from the hospital. Okay, Fayaz. Where do you work, Fayaz?
Sir, we follow the baby's growth on intergrowth percentile chart.
Which charts do you use, Fayaz?
Sir, they are gestation specific, and for a preemie baby, they start with 24 till 40 weeks post menstrual age. So the intergrowth chart that we use in our setup. So we
where do you work? Where do you work, Fayaz? Where do you work?
I work at AKUH in SU.
And which charts do you use? Like which country are they from?
Sir, the recently introduced intergrowth percentile chart is that project population from all continents. So they are specific for all population throughout the world. Though I reckon you have heard about the intergrowth interpercentile charts.
Yeah. Okay. So I think you're right that a standard growth chart, which is gestation specific, should be used for monitoring the growth, and that growth includes the weight, length, and the head circumference, and all these centiles should be monitored over the course of the clinic follow-up. So moving on, and thank you very much for very interactive discussion for the case. So let's have a look on this case again. So if this is a 1 kilogram baby, if this baby is at full 150 ml per kg per day fluids, let's have a look if what will be the calories if we are giving different preparations. So for example, this baby is just on 10% dextrose for some reason. There's no TPN. Say, for example, the milk, even the milk is not available, or we cannot feed the baby due to some reason. If this baby is on 150 ml per kg per day, just dextrose, you can see how much little calories he will get. In just few days, he will start getting really in a catabolic state. Amino will, again, this is something which is used in Pakistan, and we have recently discussed this in our academic neonatology forum as well, that this is probably not the ideal option, but because the TPN is not available in all setups, people are using this. This is an adult preparation. Again, the calories, as you can see, are very little. If you're giving a combination of 10% dextrose and amino will, you're probably not hitting more than 100 ml per kg per day, maximum maybe 110 calories per kg per day. But if we're giving full TPN, which by day 3, day 4, we should be on maximum amount of protein and lipids, which is 3 grams of lipids and 3 grams of protein, we can give around 120 to 130 kilocalories per kg per day. If we're using express breast milk, we know that the breast milk has 20 calories in 30 ml. So at 150 ml per kg per day, the express breast milk will provide 99 calories daily, which, as you can see, is much less than the required amount. The preterm formula has 24 calories in 30 ml. So if we're feeding the baby preterm formula at 150 ml per kg per day, and the daily calories will be 120 calories, and that is what is the requirement, around 120 to 130 calories per day. I think if you look at the bottom, I think that probably is the best option for this baby. Fortified EBM. If you fortify the express breast milk, and the calorie content increases to about 24.5 kilocalories per ounce, and that would equate to 121 calories daily if we are feeding that baby at 150 ml per kg per day. So you can see on this slide, the best option for this 1 kilogram baby on 150 ml per kg per day is the fortified EBM. We all know the benefits of the breast milk and express breast milk. If we can get this baby on fortified EBM on full feeds, we do not need central line for the TPN. We can avoid all the complications related to the preterm formula, and it's much better for the baby's brain growth and baby's physical growth. So moving on to different kinds of nutrition which we can provide to the preterm babies. We'll talk about the IV nutrition, then we'll talk about the different kind of milks that we can give. So as far as the IV nutrition is concerned, as I said, I would recommend that we only use 10% dextrose unless the baby is really hyperglycemic, which sometimes can happen. But even in those cases, the standard fluid in normal preterm babies should contain 10% dextrose. When we are using TPN, the dextrose concentration can be slightly higher. But otherwise, if you're using plain 10% dextrose or plain with some electrolytes, it should be 10% dextrose instead of 5% or 7.5%. But as I said, 10% dextrose on its own cannot provide enough calories and should not be used for a long time. The baby should be started on milk as soon as possible. And if that is not possible, for example, if the baby is very sick or if the baby has some surgical problems, then the TPN should be started. And as I mentioned before, I put question marks about amino will plus minus lipids, that this is something that we have, the people are using locally. This is not something which is evidence-based, but because of the resource limitations, probably this is a little bit better option than just using 10% dextrose if the TPN is not available. I won't spend much time on the TPN because that is on its own is a totally different talk. But the optimal TPN for a preterm baby, that's how it should look like, about 100 to 140 to 160 ml per kg per day of water. It should provide 110 to 120 calories per kg per day. The amino acids would range from 1.5 to 4 gram, glucose around 18 gram, lipids around 3 to 4 gram, and different concentrations of other electrolytes. The preterms electrolytes are slightly higher than the term babies, and at the bottom are the different requirements of different constituents for a term baby. Who are the babies? Which are the babies who should get TPN? I would say that anyone under 1 to 1.2 kilogram should get TPN, and that includes all the babies born under 30 to 32 weeks. Because even in these babies, it is likely that it would easily take about 7 to 8 days before we reach the full feeds. So leaving these babies on just 10% dextrose will impair their initial growth and initial nutrition. So if possible, all these babies should be given total parenteral nutrition. And also in term babies, or even any other baby who is likely to be nil by mouth because of any surgical reason, or if the baby is septic or baby has NEC, any baby who is likely to be nil by mouth for 5 days or longer should receive TPN. The next we're going to talk about, I think that's probably the most important aspect of today's talk, is milk. So the options are either express breast milk or fortified express breast milk, preterm formula. Term formula obviously is out. We are talking about preterm babies, so we'll only talk about the preterm formulas. So talking about the express breast milk, as I said, the calories content of the express breast milk is about 20 calories per 30 ml. So about 100 ml of breast milk will provide about 66 calories. The problem is when after preterm delivery, the milk which is produced by the mother has even less calories. So for the first few days, the milk which is produced, the calorie content is probably even less than 20 calories per 30 ml. So how do we overcome that problem? And the solution to that problem is that we can use human milk fortifier, which will increase the calorie content of the human milk. So one sachet of the human milk fortifier has about 4.5 kilocalories. So if we add that to 1 ounce of milk, the calorie content will go up to 24.5 kilocalories. And that means the 100 ml of fortified express breast milk will provide almost the same calories which any preterm formula will provide. So that is probably the best option for our preterm babies. So many benefits of the human milk. We can talk all day about the benefits, but huge benefits for the neurodevelopment, improved long-term cognitive function, visual function, much less incidence of different kind of infections, less NEC, improved immunity, less allergies, and a lot of gastrointestinal effects as well, better milk tolerance, less feed intolerance, and overall better growth for the babies who are given breast milk. Preterm formula, I would say avoid if possible. The fortified express breast milk is the best option. And as I explained earlier, the caloric content of the fortified EBM is almost the same as preterm formula. I think we all need to work a lot on this, that all the women who have delivered a baby preterm, obviously this will be a difficult situation for the mother. She might be unwell, depending upon the reason why the baby has been delivered prematurely. Most of these women would be septic, would have chorioamnionitis, they might have placental abruption, so they are likely to be unwell after giving preterm birth. So they need a lot of help and support from our gynae colleagues, from our NICU nurses, and from all of us to make sure that they start expressing breast milk within the first 6 to 12 hours after birth, ideally as soon as possible, depending upon how well or unwell the woman is. But this is, I think, one of the key messages from this talk, if people want to take, is that we all need to do a lot of work on supporting the women who have given preterm birth in expressing breast milk. What is the target weight gain? So the caloric requirement for any preterm baby to grow optimally is around 120 to 130 calories per kg per day. And that would meet our target weight gain, which is around 15 to 20 gram per kg per day. So for any baby who is under 2 kilogram, the target weight gain is 15 to 20 gram per kg per day. For those who are over 2 kilogram, it's about 20 to 30 gram per day. So that's where the importance of a regular weighing of all preterm babies. So they should be weighed at least 2 to 3 times a week. And if they're sick, obviously they need more frequent weighing, but stable preterm babies should be weighed 2 to 3 times a week to make sure that they are meeting this target. And if they're not gaining weight according to this target weight gain, then obviously we need to look at why the baby is not gaining weight. Where is the problem? Is there problem with the calorie content of the milk that we're using, or is there any other issue that the baby is not gaining adequate? When do we need to increase the volume of the milk, or do we need to add anything else to increase the calorie content and to optimize the weight gain? So how to decide the initial feeding methods? It all depends upon the individual patient. There is no set rule or set criteria. The gestational age obviously is the key factor in deciding that how we are going to feed the baby. That's the most important factor. The second factor is the birth weight. That what is the baby's birth weight? Is the baby appropriately grown, or is the baby small for gestational age? Is the baby growth restricted or not? All those babies who are severely growth restricted with a history of absent or reversed end diastolic flow, and they are high risk for NEC. So these are the babies who should be on cautious feeding regime, that we cannot use standard feeding regime. We have to increase their feeding much slower than normal babies. And then obviously how well the baby is, what is the cardiorespiratory status? Is the baby on the ventilator? Is the baby on inotropic support? And how is the overall clinical status of the baby? That also determines how we are going to feed the baby initially. And obviously how well the mother is, and how good the supply of the breast milk is. These are the different factors which will determine how we are going to initially feed the baby. So, well babies who are over 34 weeks and over 1.8 kilogram, they can be started on milk feeds pretty much straight away. And I'm sure this is the practice in most of the units in our country. And that should be, and this milk should be breastfeeding unless they are very unwell. So all well preterm babies over 34 weeks and over 1.8 kilogram can be started on feed straight away. For smaller group, those under 30 to 32 weeks and those under 1 to 1.2 kilogram, these are the ones who are likely to need some parenteral nutrition until the enteral nutrition is built up. So preferably TPN should be given, and if that is not possible, then either IV fluids or, as I said, sometimes the amino and lipids can also be given while we're waiting for the EBM. The important thing in this group of babies who are small is that the colostrum, as soon as colostrum is available, it should be used in all the babies for mouth care. Just even if they're sick, and there's no contraindication not to give colostrum. We can drop whatever colostrum we get, like 0.5 to 1 ml. That can be just put it in the mouth, and that can be used for mouth care. It probably will be absorbed from the mouth. It's beneficial for the gut immunology, for the gut growth, for the enzyme development. And although these babies will receive IV nutrition initially, but the trophic feeds, as we discussed earlier, using the express breast milk should be started as soon as possible at a rate of around 15 ml per kg per day for the first 1 to 2 days, preferably within the first 12 hours. This is the middle group between 30 to 34 weeks. So this is, again, this depends upon the individual baby. If the baby is well and no respiratory support is needed, then the NG feeding can be started straight away. But if the baby is unwell, the baby is needing respiratory support, then those babies will need to be started initially on IV fluids, and then the feeds can be built up fairly quickly in this group of babies. And this group of babies, if they're over 1.2 kilogram and if they're appropriately grown, they should not need TPN. So 10% dextrose initially, along with early enteral feeds, with the aim of getting on to the full feeds by day 5 to day 6, if we are increasing the feeds by 30 ml per kg per day, which is now the recommended rate for this group of babies. So we'll talk now about minimal enteral nutrition, which is also called trophic feeding. And as we mentioned before that, the colostrum should be used in all babies, irrespective of their clinical status for the mouth care. And the low volume enteral feeds or trophic feeds should be started within 12 hours of birth. And that should be express breast milk at a rate of around 10 to 20 ml per kg per day. And there's a lot of evidence now that giving trophic feeding to the preterm babies helps the maturity of the gut, and it also allows quicker time for reaching full feeds. So those babies who are given trophic feeds, they reach at full feeds much earlier than those babies who are not given trophic feeding. So I think our practice is now changing, and more of units are now giving trophic feeding as soon as possible. And overall, there's no increase in the incidence of NEC in these babies. And as I said earlier, unless the baby is very sick, aim to start within 12 hours after birth. This is a randomized controlled trial on early progressive feeding, which showed that early progressive feeding increases the number of full enteral feeding days in extreme preterm infants without increasing the incidence of NEC or any other significant side effects in preterm babies. How much should be the total fluid volume or the feed volume? As we discussed earlier, different units have different policies, but anywhere between 60 to 80 ml per kg per day on day one would be enough. The more preterm and the more small they are, they're likely to need more fluid. So if they are under kilogram, they're likely to need 80 to 90 ml per kg per day, especially if they're less than 750 gram. But over a kilogram, probably around anywhere between 60 to 80 ml per kg per day should be enough. And then either fluid or feeds, they both can be increased by 20 to 30 ml per kg per day. And the total volume is around 150 to 180 ml per kg per day. What should be the final feed volume? That needs to be individualized to each baby. Those who are small, those who are under 1 kilogram, and those who are born under 30 weeks, they're likely to need more volume for the growth. They're likely to need around 180 ml per kg per day. But those who are over 32 weeks and over 1.2 kilogram probably should 150 to 160 ml per kg per day should be enough. So if you're using fortified human milk at 160 ml per kg per day, that should provide decent calories for adequate weight gain. So that should be our target in all our preterm babies, fortified human milk at 160 to 180 ml per kg per day. The next important question is that how quickly should tube feeds be increased? And again, there's no single or straight answer to this question. This depends upon the weight at birth, gestation at birth, feeding tolerance or not, and overall clinical status. But it's important to know that once the baby is tolerating feeds of around 100 to 120 ml per kg per day, the TPN can be discontinued at that time. And if the baby has been inserted a PICC line or long line, that can be removed. So previously, we were a bit cautious with feeding, and most people would use a rate of about 15 to 20 ml per kg because of the perceived risk with either NEC or feed intolerance. But now we have now evidence that using a higher rate of about 30 to 35 ml per kg per day, there's no increase in the incidence of NEC, and there's the babies who are on rapid advancement rate, they have no difference in terms of feed intolerance, NEC, or late onset sepsis. So this is the Cochrane review from 2015 and 2016, which shows that there is no increase risk of any adverse events between the two groups. This is, as I mentioned, this was a randomized controlled trial which compared 15 ml per kg versus 30 ml per kg per day, and you can see that there was no significant difference in survival without a moderate or severe neurodevelopmental disability or NEC or any other significant side effects when they used 30 milligram per kg in one group and 18 ml per kg in the other group. So this is just a guidance. You can tailor this according to the individual baby, but as we mentioned before, a smaller group, less than 1 kilogram, for the first 1 to 2 days, 10 to 15 ml per kg per day, and from day 3 to day 4 onwards, you can go up to 20 to 30 ml per kg per day. The middle group, 1 to 1.5 kilogram, again for the first couple of days, 20 ml per kg per day, and then from day 3 onwards, 20 to 30 ml per kg per day. And for 1.5 kilogram, it's relatively easy to remember that we can, they probably don't even need to be on trophic feeds because they're bigger babies. If they're appropriately grown, they can be started on 30 ml per kg per day from the day 1. And that means if they're tolerating the feeds and we are using the fortified EBM, by day 5, day 6, they should be on full feeds. But as I said, this is just a guidance. You obviously will have to tailor the rate of increment of feed depending upon individual patient. There are certain groups of babies, obviously, who are sick and we cannot feed them, or if we are feeding them, we have to be very cautious. And these are the groups: severely growth restricted babies, where there was a history of absent or reverse end-diastolic flow, babies who are born under 750 gram and under 26 weeks gestation. We have to be a bit cautious in those as well. Surgical neonates, the babies with any kind of abdominal surgical pathology, they will, if they had any kind of surgery, we'll have to be cautious when we are starting them on the feeds. And those in the red obviously are again extremely cautious in this group. The baby is on high oxygen, 60 to 80%. If the baby is on inotropic sport or if there's severe metabolic acidosis, you can use colostrum, as I mentioned before, for mouth care, but probably either avoid feeds, or if the baby is improving, you can start slow, cautious feeding unless these issues have resolved. Until these issues have resolved. The next question is that how the tube feed should be given, and I think the current recommendations are that this should always be as a bolus feed given every 3 hours over 30 minutes, and that makes the physiology as well, because when the babies are feeding, they spend about 20 to 30 minutes on the breast. So the idea is to use the same physiology, so giving a bolus feed over 30 minutes every 3 hours. Now, very small babies, especially those under 750 grams and those under 26 weeks, sometimes the 3-hourly volume might be big enough for them, so they might need to be fed more often, like 1 to 2 hourly, to reduce the risk of feed intolerance. Very, very selected cases, sometimes we might need to use continuous tube feeding, or in very selected cases, NJ feeding. But these are very selected group of patients. The NJ feeding is usually used in those babies who have severe neurological impairment and have significant gastroesophageal reflux. In those cases, we can use continuous NJ feeding. And similarly, continuous tube feeding only in those preterm babies where they're having lots of difficulties with feed tolerance. If the baby has been on IV fluids previously and then on NG feed, at what time we can start giving oral feeds? So anytime between 32 to 34 weeks of gestation, the baby will start giving signs that they're now ready for oral feeding. So our nurses, they should assess these babies on regular basis between 32 and 34 weeks, and as soon as we feel that the baby is ready to take oral feed, the oral feed should be started. Obviously, the babies have to be well, they have to be hemodynamically stable, they have to be off CPAP and high flow nasal cannula for oral feeding. The babies who are on low flow nasal cannula oxygen, they can be given oral feed. Obviously, we have to be cautious to make sure that their respiratory condition doesn't worsen with oral feeds. We mentioned human milk fortification earlier, that because of the less calories in pure express breast milk, it is advisable that that for preterm babies, the express breast milk is fortified. So we have two types of human milk fortifiers available. The one which is available in Pakistan is bovine-derived HMF with pre-NAN HMF. The other one, which is donor human milk-derived HMF, it's called Prolect 6. It's not available in Pakistan, but it's available in the West. I would say that all the babies under 1.5 kilogram and under 32 weeks, they should be given fortified human milk. And this fortification should then continue until the baby reaches 1.8 to 2 kilogram. And we can stop it once the baby is feeding on the breast. There is very clear evidence now that using human milk fortification in preterm babies, it improves their early protein intake without any increase in any adverse events like any episodes of NEC or sepsis. Most of the preterm babies, especially those who are very, very small, like those under 1 kilogram, they're likely to need sodium and calcium and phosphorus supplements orally as well. All preterm babies should be given multivitamins, iron supplements, vitamin D supplements, and folic acid supplements once they are tolerating full feeds, and that should be continued for about 3 to 6 months, depending upon how they're growing following discharge from the hospital. This is something I came across when I came back last year, that people were using this. I had never heard of this before, but this was being used as a protein supplement to increase the caloric content of either the breast milk or the formula milk. But when I was looking yesterday, when I looked on this is from Nestle, the bean protein, but it clearly says, you can see here, not for use in individuals younger than 3 years old. You can see it here. So I would say that we probably should not use this in our preterm babies, because this is not a product designed for preterm babies. As I said, if you're fortifying the express breast milk, there are enough calories in that fortified EBM to provide optimal nutrition. And this is another thing which people I've seen people using Phantomalt. Again, I would say that this is purely a carbohydrate oral supplement and probably should only be used in some metabolic disorders where we need to increase the carbohydrate content. So if possible, avoid using this in preterm babies to increase the calories. Few more slides about, obviously this is again a common problem when we start the babies on the milk feeds. The feed intolerance occurs, commonly seen in babies who are small, those under 28 weeks, those who are on the CPAP or ventilator, and those with a history of sepsis. And it's usually because of the preterm gut rather than because of any disease. Usually it's just the gut is immature and just needs a bit more time to tolerate the feeds. The factors which affect feed intolerance are that what kind of feeds we are using. If we are using express breast milk or fortified EBM, the chances of feed intolerance are less. How quickly the feeds are being increased, what volume is being used, what are the other medications being given to the patient. All these factors, they affect feed intolerance. The baby might have other medical conditions which can affect feed tolerance. One other point which I have highlighted in the red here is that I've seen people and nurses sometimes using different medications or supplements adding to the milk feed. I think we have to be very careful that anything you add to the express breast milk will affect its osmolality, and the osmolality of the breast milk is about 300 milliosmoles and shouldn't really go up beyond 400 or 450 milliosmoles per kg. And if the osmolality is very high, it can not only cause feed intolerance, it is a risk factor for NEC. So we should avoid adding any medications or any unnecessary supplements to the feeds, to the breast milk. And the only supplement I would recommend we can add to the human milk is the fortifier. So the symptoms are, as we all know, there will be increased, there might be abdominal distension, vomiting, increased gastric residual volume. It's the color of the gastric residual volume fluid is also important. Green obviously is bad. That shows that the baby might be septic or early NEC. Whatever is the reason, the green milk NG aspirates, and the baby has to be assessed carefully. Probably the feed started on IV fluids and screened for sepsis. In terms of the gastric residual volume, if it's less than 25% of the feed volume, probably can continue feeds and monitor. But if it's between 25 to 50% of the feed volume, then it's probably better to either omit one feed and reduce the next feed and monitor. But if the residual volume is more than 50% of the feed volume, then withhold 1 to 2 feeds and restart at a lower rate and monitor clinically. The important thing is that any baby who is showing any symptoms of feed intolerance should be very carefully assessed medically to make sure that the baby does not have sepsis, the baby does not have NC. So these are the two conditions we don't want to miss. So all these babies should be very carefully assessed on regular basis. And if the feeds have been stopped and restarted, the ongoing clinical assessment should continue. All of you probably have seen all these medications being used in neonates who are showing feed intolerance or who have a history of reflux or vomiting. Essentially, there's no evidence that any of these help in improving feed tolerance, so we should avoid using it. Only use if you really need to. I mean, personally, I have only used omeprazole in very, very selected cases, but in normal standard preterm babies who are just showing mild to moderate feed intolerance, it's better just to stick with the feeds, and it should just get better. Metoclopramide, I would say a big no. I've never used metoclopramide, but I have seen cases of some serious side effects associated with metoclopramide, especially seen few cases of acquired methemoglobinemia where babies have become very sick because of the metoclopramide. So I would say, please, if you're using, please stop using metoclopramide in neonates. How we assess that we're providing adequate nutrition to the preterm babies. These are the three obviously parameters which help us in determining that we're providing optimal nutrition. That's weight gain, as we have discussed that before, how much should be the weight gain. The length and OFC should increase by 1 centimeter per week. And we should use gestation-specific growth charts which are designed for preterm babies, so that we know that on which centile the baby has started and whether the baby is growing up on the centiles, growing along the centiles, or growing down on the centiles. Lab monitoring, again, the babies who have been in the NICU for a long time, they need regular lab monitoring using hemoglobin, albumin, calcium phosphate, albumin phosphatase electrolytes. This is more for extreme preterm babies, especially those under 1.2 kilogram and those under 30 to 32 weeks. One of the colleagues had mentioned growth charts earlier. These are the ones which I am using, and these are UK WHO growth charts, and they start from 23 weeks and they go to 2 years corrected. And I think anyone who is working with in NICUs or with preterm babies, or who is going to follow up these babies, each baby should have one of these charts with them, and you can see that they start from 23 weeks, and it's a really useful tool to assess that a baby, how well the baby is growing. It gives an excellent idea on one glance about the overall nutritional status of the baby. And we all know that it's not just the weight, it's the head growth is as important as the weight gain. So regular measurement of the head circumference, regular length measurement, and regular weight, and plotting them whenever we are seeing them in the clinic or even during the NICU stay, and the growth should be plotted at least once a week on this chart, and that will give us an idea during their stay in the NICU whether their growth, the rate of growth is optimal or not. You can, if you want to use these, you can easily download them from the internet. So we're almost reaching towards the end now. So what should be the criteria for discharge. So ideally, the feeding by mouth at 150 to 180 ml per kg per day, and ideally feeding on the breast. That is when the babies can be discharged. And at the same time, they should be gaining adequate weight, which is for less than 2 kilograms is around 15 to 20 grams per kg per day. And for those over 2 kilograms is around 20 to 30 grams per day. That's not per kilogram. So those are the figures to remember. As I mentioned, ideally the baby should be on the breast milk at discharge, but obviously there will be situations where either the breast milk was not available or there was some other reason and the baby has been on preterm formula. In those cases, again, it's an individual assessment for a particular baby. If they have been gaining weight adequately at around 1.8 kilogram, you can switch to the term formula. But if the weight gain has been poor, or if the baby was very small, or if there's history of intrauterine growth restriction, the preterm formula can continue until the baby is a bit more mature, like about 2.5 kilogram. The transitional formulas are available in the West, which is in between the preterm formula and the term formula, but they're not available in Pakistan. So if we need to use a preterm formula, that will be just the standard preterm formula, which is used in the NICU to be continued. But as I say, ideal milk for the babies at discharge is the breast milk. As we discussed in the beginning, there are situations in Pakistan where a preterm baby has to be discharged on tube feeding because he's otherwise well, is not on any respiratory support. And the only reason to stay in the NICU is that the baby has still not started taking feed orally. So those babies can be discharged home on NG feeding if the parents have been trained in how to use the NG tube at home. And I think that I have now started discharging babies at around 1.3, 1.4 kilogram, where the parents cannot afford to stay in the hospital anymore. And I've seen that the weight gain remains optimal even after discharge, because the baby is not spending too many calories on sucking from the breast or from the bottle, and they can use those calories on the weight gain. And by the time they reach about 1.8 kilograms, then I usually tend to remove the NG tube and the baby goes on full oral feeds. But these babies, then they need very close clinic follow-up, I would say about once every week initially, to make sure that there are no issues with NG feeding. We have already discussed in terms of the follow-up that we should use standard growth charts, which are gestation specific. On each follow-up visit, the baby's feeding, weight gain, overall growth and development should be reviewed, and we can also review the need for supplements and duration in the follow-up. So to summarize, express breast milk is the best milk for babies, and use fortified EBM where indicated. Feed the babies early. We can use a slightly higher rate of feed advancement than previously practiced of 20 to 30 ml per kg per day. The target feed volume is 150 to 180 ml per kg per day, and the target calories are 120 to 130 calories per kg per day. The target weight gain for small babies is 15 to 20 grams per kg per day, and close follow-up of all preterm babies using standard growth charts to monitor their growth and development. Thank you. That's all from me. We'll take any questions now.
Thank you very much, Dr. Yasser. I would like to ask participants.
Yes, Fiaz.
Yes, sir, my question. Yes. Am I audible?
Yes.
So my question is that you mentioned residual volume of the OG feeds. I was going through a recent article that was emphasizing that there is no need for checking the OG residuals. So what you think?